Wednesday, May 31st, Health and Human Services Committee meeting to order. Will you please stand for the Pledge of Allegiance? I pledge allegiance to the
Pledge allegiance
of the
flag
United States
of the United States of America
Republic,
and
which it
to
stands, one nation, under God, indivisible, with liberty and justice for all.
the
Thank you. Moving on to public comment. We do not have anyone present and nobody signed up ahead of time for public comment. So I'll bring us to item 4, approval of the May 3rd, 2023 Health and Human Services Committee meeting minutes, which were in your packet. Do we have a motion? Motion by Covelli. Is there a second? Second by
Supervisor.
Second by Supervisor Goddard. Thank you. All those in favor of approving the minutes, say aye. Aye.
Aye.
Opposed? All right, none opposed, motion carries. And I think if there are no objections to taking the agenda out of order, I'm going to skip to 7, the educational presentations, so we have a chance to hear from the 2 departments that are here, and then we can continue our discussion about the budget, if that works for everyone. So we'll move to item 7, educational presentations and committee discussion. 7A, department and partner updates on programs and services. A1, health department. So that brings us to Laura.
Hello, everyone. Thank you for having me here today. And I am going to walk you through the services of the health department, and I will especially highlight those services that are not required or mandated services as was requested. What you have in your packet, I also have beautiful copies here. They're actually, some of them are literally still hot because they were fresh off the presses. It is in the packet, it is on our website also, but if you'd like a paper copy, just let me know. It is oh, you won't, see? Because they're so beautiful, right? Okay. And in that packet is a lot of really great data. I was thinking about you when I was putting it together, Ron. And so we do this every year. It is actually statutorily required by 251.06. And it is our annual report. So we provide that to the state. We're breaching normal protocol a bit because you are seeing it before the Board of Health, who has yet to review it, but they will be reviewing it in June. So starting off on page 5, we're going to skip around a little bit within the annual report. On page 5 lists our essential services. So these are the services that are required to perform, that we are required to perform for the community. These services include Pass them around. These services are include monitoring the population health and surveillance, building partnerships to improve health. We're also tasked with building a competent and diverse workforce. So then on page 7, you'll see a brief overview of our main programs. I want to point out that this is 2022 data. So be aware that there have been changes that have been made since last year. So, we will, around this time next year, we'll be doing 2023's report. But this is for 2022. So some of the things you will see in this report that may not happen in the next report is there is a very specific COVID section. And our monthly COVID numbers have decreased in 2023. So in an effort to be good stewards of our resources, we decreased our COVID team. So that would be an example of one change to the COVID staff by the MCHD staff by the numbers. So the staff that are listed here have to be skilled in core public health competencies. Not many people understand that public health is a very highly technical field involving epidemiology, evidence-based community coalition techniques, food safety, and medical knowledge. We have skilled public health nurses, and our directors either have over 20 years of public health experience or a master's degree in public health, or both. We employ sanitarians, lab specialists, public health nurses, and certified health education specialists to carry out our work. On page 9, you will see our newly created dashboard. So this is something that we've developed as a part of our results-based accountability framework that we use quite a bit in public health. This framework asks the questions, how much did we do? How well did we do? And what difference did it make? And so essentially, when we look at those questions, when we look at how much did we do, it's really about outputs. How much service did we deliver? How many widgets did we make? When it talks about how well do we do, how do we know that the service was performed well? How do we know that? And then what difference did it make? is anyone better off? It's really measuring what improvements in skills, attitudes, behaviors, or circumstances were made. So this is the first year that we've done this kind of dashboard. This dashboard is really a starting point. It's really a work in progress. Many of the data points exist on Marathon County's Pulse website, but some are actually collected manually. And so you will see, because we are starting to collect data that we haven't collected before, there are some missing points of data. This would be the first year that we collect. 2022 would be the first year we collect data. And going forward, we would collect those data points. So you'll see in the dashboard that every single program has maybe a sub-program. Let's say, for example, in the community health improvement, we do alcohol and tobacco work, we do substance use work, we do mental health work. So all those different activities have those 3 questions in mind, and then data related to those questions. So we did that for all of the programs at the health department. Community health improvement, environmental health, and then family health and communicable disease. So I'll keep going, and then we can come back to the data as we have questions here. So on page 15, you will find the community health improvement program and information about that program. At a past meeting, you expressed to me that I should express to you if I think we should need to expand any part of our program, or what parts of the Marathon County Health Department could benefit from additional resources. And I really think that it's in this program that we would find the biggest bang for our buck. So right now, health educators are largely grant funded. So those community health educators are the individuals that you would see. They've come and they've done different education sessions for us. They've facilitated meetings. Some of you have been involved in meetings that they've facilitated. And all of our health educators are actually community health education specialist certified. So they have to get a certain number of public health hours. And in addition to that, they also have to take a very rigorous test. So I know that because I did it myself, and and I don't want to do it again. But it's a great program, and what it does is it really sets people up to be very good facilitators and to really understand coalition building and community level change. So since all of our health educators are grant funded, we look for grants to support work that is given to us by the county board through your strategic planning process. And the program is currently doing work on mental health and substance use. But once the grants run out, we will be in need of levy funding to support these positions. And we need to look for, in the meantime, we're looking for supplementary funding. There have been several new initiatives that have been forming since our positions are grant funded. They have very specific scope of work with very specific outcomes. So we couldn't use them necessarily in other activities because they have a full-time scope of work that is required for this grant. So the grant would not allow us to use like tobacco funding on COVID, for example. So I think a really great example about this is the county received a grant for child care discussions. Child care is a key social determinant of health, and it quickly became apparent that someone needed to own that grant. So we convened key stakeholders in the community to determine the best way to use those funds. It became apparent that we really needed somebody that can facilitate those meetings, can facilitate community change, and we were happy to step forward and play that role. That kind of role really takes a skilled facilitator, and we were really only able to accommodate that need because we were receiving some funding for the health educators' time through that grant. So, as things arise, having levy-funded health educator positions would actually allow us to address issues that come up periodically that we don't anticipate and we don't have grant funding for. So just a few issues that have come up this year: homelessness, housing issues concerning mental health and suicide rates in schools. Since we don't have levy-funded positions in this program, this makes us less adaptable and flexible to these needs as they arise. So we're going to move on
Laura,
to yes.
do you want to wait until the end to take questions, or can you take questions?
I can take questions anytime.
Okay. Supervisor Covelli, go ahead.
Thank you, Madam Chair. And thank you, Laura, for the presentation. While we're talking about grant-funded programs, are these funded programs listed someplace where there's a timeline and when the timeline's going to run out for the grant funds?
We do have that at the health department. We have about, I think, 39 different grants that we are participating in at any given time that run our, different things from tobacco to alcohol, compliance checks. And so a lot of them operate out of the Community Health Improvement Program. We could put a list together for this committee if that would be.
Okay, I think, if you have some grant funds that are going to be running out, maybe in 2023 or 2024, it would be good for us as a board to know that so we can maybe think about adjusting, for levy and different things like that to help either, keep those programs going or at least get some education on that so we can plan ahead. Thank you.
That we can do. We can help you anticipate those needs. Okay, so on page 19, you will see the CHIP plan. So I'm just, we like to put that in all the time because I want to keep it out in front of everybody. This is, again, it's statutorily required by us to provide a community health improvement plan. Again, we call it the CHIP. And this is in addition to the CHAW, the community health assessment, which is actually coming out tomorrow. So I want to just put a plug in for everybody to, if you're available and can participate in the life report tomorrow, that would be great. But the CHIP plan is community-based work that the community health improvement team actually do as a part of their annual activities. So their job is to move forward the strategic direction of the CHIP plan. So it's in there for your reference. We've gone over it before, so I won't go over it in detail again. Then on page 20, we have the environmental health and lab. These functions are not required or mandated functions, but we do contract with the Department of Agriculture, Trade, and Consumer Protection, and we use registered sanitarians to license restaurants, pools, and mobile home parks. They also respond to foodborne outbreaks. We just had a foodborne outbreak a month ago, and thank goodness we had sanitarians that were able to respond to that to help protect the public. When those happen, we have to respond quickly to identify the source of infection so that additional people do not get sick. The service can be contracted through the state, but there would be an additional cost, and I have heard that that the service may not happen as frequently as our inspection schedule currently is. So we inspect every place at least once a year. Some places require more additional inspections, and from what I've understand, that it might not be as frequent if it was on the state schedule. So you might get a less effective service, and generally this program covers its costs with licensing fees, so it manages its own costs. We also participate in a number of mutual aid agreements with surrounding counties, which would be impacted. Mutual aid is offered during a large outbreak or an outbreak that crosses county lines or some kind of large public health emergency. So that would be impacted, our ability to help with those and also receive aid in return. So we also have a water testing lab, which tests water for microbiological and chemical factors that impact health for local well owners. The lab does our rabies follow-up work as well as providing education on water safety. And while the service does not cover the cost of the lab alone, when it is encompassed in the overall EH program, the licensing fees cover the cost of both the environmental health program in totality, so the lab and the sanitarians work. Are there any questions on that so far? Okay, so we're going to move on to page 23. So this is our family health and communicable disease. These are our public health nursing programs. Communicable disease work is state mandated in State Statute 252 and Chapter 145 and 146. This program includes our immunization activities, which are directed by the state. Family health includes the Nurse-Family Partnership, and I just want to mention that this report refers to Start Right, and this was because this report is reflecting 2022. We moved to the Nurse-Family Partnership as of March 2023. So our new Nurse-Family Partnership program reduced levy spending by 7% this year, and we expect a further reduction of 15% in 2024 as our startup costs will be expended. So we do anticipate a further reduction of levy in the next year. We also recently signed on as a collaborative partner to a competitive grant regarding home visiting. So it would actually potentially pay for $18,000 per year of program costs if accepted. We continue to seek out grant funding to support this. I just want to mention here that that this program, in addition to our Children with Youth with Special Healthcare Needs program, some of us call it CISION, some of us call it Cushion. I like Cushion, but it hasn't caught on yet. But I want to mention that, when our County Administrator Leonard talks about a dollar not being a dollar, this is a really great example of that. And the way I explain it is that we operate this Children and Youth with Special Healthcare Needs program, and it is a regional model that connects families to necessary supports for kids with special needs. This program is fully covered by grant dollars. It pays for itself through this grant. But we have to attest that 75% of the program is that the cost of the children, youth, and healthcare needs, we spend that in addition in maternal health. So if we would lose the nurse-family partnership, we would also lose the children with youth and special healthcare needs program in addition to all the indirect that comes to help support the department overall. So a dollar isn't a dollar. It actually impacts two programs instead of one. And I think Supervisor Robinson, you've talked about that before as well. Okay, and then on page 28, so there's some information in here in addition by the numbers we have in here. Just gives you kind of a sense of some of the important pieces and figures that you might find important in your advocacy and discussion about our programs. And then on page 28 and 29, we do have some family health and communicable disease indicators. So those are actual disease surveillance data. So how many people that have hepatitis C in our community, how many have experienced Lyme disease, and these are reported. So these are reportable diseases. So clinics that have a patient with this disease are required to report this disease. Does that always happen? Not always, but ideally it happens in that way. Okay. All right, and lastly, I'd like to show you on page 31 is just a pie graph, which we talked about at the last HHS meeting about a desire to understand the revenue and expenditures for the health department. So we did include this pie graph for you. So this is our total expenditures for 2022, and I do want to mention that our COVID funding was did reduce our need for levy in 2022 as we were performing COVID activities at the time. We also had reduced levy funding because of the change to the Nurse Family Partnership Program. It did reduce our expenses quite a bit, and our levy expenses specifically. Again, we do anticipate further levy reductions to the because the Nurse Family Partnership the startup costs will have been completed by 2023. So that is what we are anticipating for 2024. We tried to pack as much data into this as we could possibly do.
Thank you. Go ahead, Supervisor Cavelli.
Thank you, Madam Chair. You said can you repeat the numbers on the Nurse Family Partnership startup costs versus the ongoing costs?
Sure, let me pull up my... With Start Right, our overall program cost was about $912,000 approximately. For 2023, our costs were $785,000 approximately, and then in 2024, we expect it's going to be $695,000. Now, that's not just levy, that is the total cost of the program. We do receive some payments through Medicaid and health insurance for the services that we provide. So there is some revenue coming in addition to that.
Okay, thank you.
But I do want to mention that, so we reduced levy spending by 7% this year, and we expect a further reduction of 15% in 2024.
Okay. Are there any other questions? Ron, I don't know if you had any that you wanted to ask from what you sent me.
Oh, just on the conversation in my text.
Oh yeah, it was just a decrease in the levy. So that
Yeah,
answered that.
so the only comment, and I think I discussed this with Lance before, after our last meeting, was I understand, state mandated programs and the costs associated with those. My question after our last meeting was that for the non-mandated programs that we have in the state, and how we fund those, and I understand some are through grants, and then the others that are funded through levies. I was looking for a breakdown in what we actually, the programs cost through levy versus grants and things like that, so.
I think if I could speak to some of that, I think that some of the grants we get are actually considered mandated because they are part of our CHIP and CHAW plan. And so generally in community health improvement work, we really consider that as furthering the CHIP plan. And so we consider that a mandated service. So the ones that were the non-mandated services that was in your packet were the children and youth with special health care needs, the licensing program, and the nurse family partnership home visiting. Those were the three programs that are in part levy funding or fully levy funded. So the children with youth with special health care needs is non-mandated, but again, it's completely covered by a grant cost. So it doesn't accept we don't need any levy funding for that program, but it is a symbiote to the nurse family partnership program.
And if for some reason we did not run a water testing lab anymore, what would be the resource for people and businesses? Would they have to mail samples somewhere?
There are private labs. If that, I could do a little more research on what that would look like. If that would be.
No, I think that's a good answer. It helps me have an understanding.
Oh yeah, and there's a state lab too. Thank you, John. Our water expert.
If I can just make one comment, I think Laura's presentation highlights, and this is something that we brought up yesterday at Environmental Resources. One of the things that staff do, building on your point, Supervisor Covelli, is, we seek out grants, like Laura said. Not only is Nurse Family Partnership saving money from based on the model change that staff made, we're still delivering the program that the county board has asked us to deliver for a great many years, and that is a nurse home visiting program. The model changed from StartRight to the Nurse Family Partnership. But even this year, Laura found a grant, her and her team found a grant. The county board has said they want the program delivered. We're going to reach out and at least see if we can get a grant to alleviate some of the cost this year. It might be a little bit problematic for us next year, but public health is a great example of a department where that's what we do all the time. To your point about are there a lot of grants that are on the verge of going away? A lot of the grants at the health department are pretty stable. They're long-term. I mean, the state has asked us to do work around tobacco and prevention for a long time.
Yeah.
So a lot of those streams are pretty stable. That said, they tie the grant money to some things they want us to do. Right? I mean, the state, I use the analogy, we are an arm of the state of Wisconsin, and they use an arm just like you or I do to affect their will. If they want us to do a certain thing with our tobacco money, they're going to put that in the grant or the state aid tied to that work. So we do that across the board. If you tell us, hey, no direction other than, quite honestly, silence, like keep doing the same programs and services as the year before, we're going to do our best to do that. Reach out, apply for grants, find more efficiencies, model changes. It can be a little bit challenging with, living from grant to grant, but particularly in public health and some of our other health and human services areas, that's pretty normal. I mean, same is true with highway. I mean, they largely tie their state aids to what they want done.
Okay, if there aren't any other questions for Laura, thank you. And then we will move on to 7A2, Aging and Disability Resource Center of Central Wisconsin. We have Mike here with us.
Thanks for inviting me to present a little bit today, information in regards to the ADRC. So our annual report is not completely done yet. It is almost hot off the press. I have a copy, but it's not officially done, so I won't be going over that with you yet, but I will be coming to the full board and presenting that at some point in time. But just to give you a little bit of what we are and how we're formed, I think would be helpful for this committee specifically in that the ADRCs are required in each of the counties in the state of Wisconsin, along with aging services or the Older American Act programs. Some counties choose to have those as separate offices where they would have an ADRC office and an aging office. We actually combine that. We call it integrated. So we integrate both the aging and the ADRC services under one umbrella. We were also, as an organization, we're a regional organization that serves 4 counties, and that was developed through an intergovernmental agreement through those 4 counties. So the 4 counties, Marathon, Lincoln, Langlade, and Wood County, formed us as an organization through this intergovernmental agreement to provide the ADRC and aging services for those 4 counties. I can get on a really big soapbox and tell you the efficiencies with that process, and I've been trying to say that across the state, but not all of them are listening to me. But at this point in time, there's only a few of us that really have this true regional model. We're almost an anomaly within the state of Wisconsin, but there are extreme benefits to how we are formed. And one of those is that we're pretty consistent in regards to how the counties support us. So we do secure some levy from each of our counties, but that levy has remained stable since the formation of our organization. So we've not had an increase in that levy since we've been formed, which is really nice for counties because you know it's what it's going to be. It's not going to go down, but it's not going to go up for the most part. If it, I will say that, obviously we all know that the aging population is growing. Our numbers are expected to continue to grow through 2040, which is quite a few more years out, and continue to increase. Which, when you have the volume continue to increase and your funding is staying stable, it creates a lot of challenges that we're trying to meet. So the majority of our funding is through state and federal grants, and I really feel that that's the purpose and where it should come from. The county levy, we do utilize this as dollars to supplement some of our programs, and most specifically recently it's been our nutrition program, because it's not funded at a level from the state and federal grants to really sustain those operations, especially within the last couple of years. So when you have the cost of food and gas and all those different things escalating, and you have a very flat income coming in, that creates challenges. So we've utilized some of our levy to be able to plug some of those holes, and the utilization, we received ARPA dollars, which also was a big contributor to us being able to continue those services. So, looking into the future, what that looks like, we're starting in that planning process, and I'm not ever going to promise that I will never come to the counties and request an increase in levy. I just don't think that that's realistic, but that's not my intent. My intent is that we hopefully can do some through legislation at the state and federal level to support these programs and not put that burden back on counties who are already overtaxed. So what do we do as an ADRC? We have a variety of different services, and I do have some brochures just to highlight what those services are. But one of the biggest things that we always indicate, you could pass those out, absolutely. Thanks, Ron. The biggest thing we always say is that if you're running into, if you personally or people that you know have anything, any question or concern or situation related to aging or disability, that we're your first contact to be able to, as a starting point, to help you get guided in the direction you need to go. So we really are the entry point into that in helping people understand what resources and supports are available for them. Our goal and intent is to keep people as healthy and as independent living in the situation that they prefer. Most of the time that is within their own home, which has a lot of benefits. One, they're healthier and happier, and two, it's more cost effective. If you can help support people within their own homes, it's a cost effective aspect as well. So what that looks like for us is we have staff that can walk people through those questions, help them identify what options of support are out there and available, help them understand what those options are, help them understand what they may cost, how to utilize their own personal resources if possible. And if they don't have personal resources to be able to do that, then we are also the entry point into the publicly funded programs, Family Care and IRIS. You may have heard them referred to as Inclusa or Lakeland. We're the entry point into those agencies as well. But that's just one service line that we provide. We also have we also provide support for caregivers. As many of you know, that people don't always choose to become a caregiver. They become a caregiver due to an event of a family member or a neighbor or somebody that they know, and now they're a caregiver. And what does that look like, and what does that mean? And how are they supported to be able to do that job effectively while taking care of themselves as well? So we do provide support to those caregivers. And within the last couple of years, we got a new service line, a dementia care specialist that really can help individuals and families that are either newly diagnosed with dementia or going through dementia in understanding what that disease process looks like, how to support that loved one, what the progression may be like, provide some education and support along that journey. One of the biggest things that we provide that you're probably most familiar with is our meals, our nutrition services, and in providing Meals on Wheels and senior dining within our 4 counties. Now, within Marathon County specifically, we're still trying to open a senior dining within the Wausau general area, but we do have the Hmong American Center cultural dining site that we just opened within this last year, which has been hugely successful. Around 30 individuals come to that on a weekly basis. So every Thursday they have a meal there. So I am also a statistics guy, so I do have some statistics for you if you are interested. So over this last year in 2022, our agency took in a total of 92,800 calls just coming into our 4 counties. During our service type level breakdown, we were able to serve within our resource specialists specifically. That's the staff that would help talk about different options. They had over 25,000 contacts of individuals, serving almost 20,000 individuals 60 and older. So as these numbers increase, those numbers will continue to just escalate. And we've seen that pattern, just looking at our data from 2021 to 2023, just in our first quarter of this year compared to 2021 data. In 2021, we had a call volume coming into our resource specialists of 21,000, and first quarter of this year is 24,000. So with the same level of staffing. So we've had to be really creative in how we deliver our service and how we provide that service to our customers to make sure that we're still doing it effectively without creating waiting lists or having service interruption. So to this point in time, we've been able to do that. We've had to honestly really look at our service and how we deliver it, but I think we've done pretty well so far. So with that, I would entertain any questions you guys have in regards to what we do.
Thank you, Mike. Are there any questions about the ADRC?
That's awesome. I always get off the hook pretty easily.
Okay, well, great. Thank you for the information. So we will bring it back then to item 5, policy issues, discussion and potential committee determination. 5A, continued discussion regarding 2024 annual budget and policy recommendations from committee. 5A1, review of mandatory and discretionary program document. We did talk about this at our last meeting, but is there any follow-up discussion anyone's looking to have or questions that haven't been answered yet? Okay, so if not, then 5A2, the review of rates and fees document. We did talk about that briefly also at our last meeting. I didn't know if there was follow-up questions. I know the health department shared a little bit about reviewing their rates and fees. Go ahead.
Thank you, Madam Chair. I guess my only follow-up question would be if any of the staff has anything new to report, if you've had a chance to look over that information and have recommendations or any further details for us regarding your own fees.
So we're going through a comprehensive evaluation of all of our fees, so that is in process currently. So we have a plan to bring that forward in August.
Great. Okay, then 5A3, the review of the 5-year departmental expense and levy document, which we also reviewed last month. Are there any other questions or discussion? Okay, so I'll just kind of open it up a little broader then. Discussion about, budget and policy recommendations. Is there any discussion anybody would like to have at this time? We'll be hearing from the rest of the departments that report to us at future meetings, so we can work on those recommendations. If you want to save them until that point, that's okay as well. All right, I'm going to take that as we're good for now then, and continue with the agenda. So item number 6, operational functions required by statute, ordinance, resolution, or policy. We have none. And that brings us to item 8, next meeting date and time, announcements and future agenda items. Committee members are asked to bring ideas for future discussion. You can send those to me. We still have a few departments we're hearing from, so if there are specific questions that you have about their programs or their budget, make sure to be thinking about those and send them to me so I can make sure that they're ready to go. And then 8B, our next meeting is Wednesday, July 5th. I did send an email asking if people were available that day since it is a holiday week. So if you could get back to me maybe by the end of this week so we could determine if we're going to have a meeting, and if not, when it would work to reschedule it for the clerk's office. That'd be great. Brings us to 9. Do I have a motion to adjourn? Motion by Supervisor Covelli. Is there a second? Second by Supervisor Leahy. All those in favor say aye. Aye.
Aye.
Okay, we are adjourned. Thank you.